Okay, good morning, everyone. This morning, we're going to be back on the trail of H13. And we're going to just do some follow-up questions with the agency before we start markup. So Alicia, hi, and is Mark, is she?
Yeah, Mark,
Okay.
yeah.
Can you join us here for questions?
I'll take that seat.
Oh, nobody wants to see. Put a sign on it says hot seat.
I know. Good morning.
Morning. So, I'm sure you've been keeping track of testimony throughout the last couple of weeks. So one of the things that we wanted to follow up with you on was the, state's, obligations and proposal to meet the Medicaid access rule, that was released, earlier in 2024. And because that obviously plays into the work that we're talking about in H13. So I'm just wondering if you can describe a little bit what the agency's plans are with regard to that.
I will be honest, I am not prepared to answer those questions in detail today. I didn't realize that that was going to be a topic of conversation. I apologize. Oh, for the record, Monica Ogilvy, Medicaid Director, Agency of Human Services. Be happy to come back and provide some additional information. We have updated, I can say that we have updated our measurement and metrics for ensuring that we are in compliance with access. But I would have to pull together a little more detail to be able to answer those questions with specificity and accuracy.
Okay, and I do want to acknowledge that I did receive from your colleague, the memo that essentially just showed what recent rate setting actions have been in the last few years. It didn't really lay out a plan for what the future would be, but realize it's a work in progress. So that was essentially the question that we had. I don't know if anybody has any other questions or anything? Okay. Yeah, oh, okay, sorry, go ahead.
I don't know if this is gonna be on topic or off topic, but I just want to ask discussion, what are some of the challenges and barriers or reasons why an individual that's on Vermont Medicaid couldn't like access the rehabilitative services in New Hampshire, and New Hampshire gets reimbursed by the Vermont Medicaid? Am I off on this question?
It's not on topic, but we've got people here who might be able to answer.
Yeah, and I just always wanted to get, do you get where I'm going with that question?
I think I do. So
Yeah.
generally speaking, if there is an out-of-state provider that wants to engage with Medicaid and become a Medicaid enrolled provider, they can. There's a process through it that we go through to establish rates and to work out what that would look like. But we do that pretty regularly where we don't have services available, especially in state. So so simply put, barring not knowing the specifics around the provider you're talking about, that's something we do pretty regularly.
Yeah. Oh, is all right if I follow up with an example. Granite City Recovery. For an individual for Vermont that's on Vermont Medicaid,
Yeah.
to be able to go on over and utilize Granite City Recovery Services,
Yeah.
which offer extended treatment. What does the state or that individual have to do in which they get reimbursed through Vermont Medicaid? Granite City would have to apply to Vermont Medicaid, and then those things get looked at?
Yes. Are we talking about Granite Valley Recovery? Centers?
Yeah,
Okay.
excuse me, yeah.
No, there could be more. So I wanted to make sure we were talking about the same organization. So we actually went over to visit them.
Or Granite State Recovery. right?
Yeah, we
Yep.
went to visit them because we wanted to see what their model looked like on the ground and talk with some of their leadership.
Yep.
It was a great opportunity for us to do some peer-to-peer learning because we do some things differently in Vermont. And obviously there's a strong interest in their model and bringing some of those components and elements to fill the gaps in the system, like we talked about yesterday with the secretary's testimony. So we actually have engaged with them about becoming a Vermont Medicaid enrolled provider.
Okay,
Yep.
great.
Yeah.
No, thank you very much.
Yeah, and that's not done, it's not a done.
Yeah, but at least the conversations have been put on out there, there's opportunity, to explore the opportunities.
Yeah.
Great,
Of course.
thank you so much. Thank you.
Thank you. Okay, folks, so now we are going to enter the stage of markup. And for people who haven't been through that before, it's kind of really the space where we go through literally line by line of the bill as written. And we agree, we make changes, we have discussion, and to do that, we have Ledge Counsel who is here. And the other thing, as a sort of FYI, so you'll want to pull up the draft of the bill. If you don't have it online, you might have a written copy of it. Here someplace.
Do you want me to put it up on the screen?
Sure. Spoiler alert, I had mentioned to Jen that in terms of sort of like organization of the bill, rather than doing a repeat and building on what's there, I thought it might be cleaner to essentially, I don't know if I'm using the right word, but repeal the stuff that exists currently for designated and specialized service agencies, because that's just kind of one component of a service of the home community-based service providers. And really focus in on all providers of home and community-based services. And one of the things that I thought it would be important to think about is whether in fact we're not actually defining providers, but thinking about services. Meaning that, there could be other providers that come into the space. That was in my delirium last night.
I'm sorry, I just got an email. I just want people to be aware, maybe keeping your thoughts this morning. Patty McCoy is waiting for transport from emergency room to Dartmouth Hitchcock this morning for an unidentified prior heart condition that she may need surgery for. So just to keep her in mind.
Oh, thank you for sharing that.
Yeah, just.
I knew she'd been really sick.
She had been feeling worse and worse, and she went to the emergency room last night, or this Tuesday morning, she went to the emergency room, got a bazillion tests.
You just
She
don't,
has
we
a
don't,
heart condition.
Yeah.
So, I'm sorry.
Yeah.
Okay, so just that's,
yeah,
right. Thank you for the reminder. But I want people.
yeah, just keep her in your thoughts and prayers. Attention to your vitamins.
Yeah.
Yes. All right.
It's a good reminder.
It is a good reminder,
So Madam Chair, Jennifer Kirby, Legislative Counsel, I did attempt to kind of mock up what that might look like. So I don't know if it's helpful if I put that into I created a strike all amendment just to work from, and put that in with the,
Great,
the bold and highlighting. So do you want me to put that
yes.
document up? Okay, I just did this morning.
Yeah. Well, it's a, so for people going through this process for the first time, so if you're the sponsor of a bill and you have an idea about how you want to change the original bill, you can talk to Ledge Council in the process and you can propose it to your committee of jurisdiction when you're taking up the bill. You can't do that for somebody else's bill. Unless you're sitting here in the, right, well, unless you talk to the sponsor, but, so sometimes that's helpful in sort of moving the process along. It also gives Ledge Council a little bit of advanced time to think about the, how they might structure it and how the wording goes and everything, so, yeah.
Just did it in the amount of time.
No, I know, I give a little bit of a bit form about that.
Since it's up, is it possible that we could also get it on the committee page so we can look?
Yes, I will, with the caveat that the chair has not even seen it. So,
I have, it's okay, that's all right.
Yeah, if it's up here, then
let me take it down so that I can send it to Lori.
thanks.
There you go. Can you grab me a tissue?
Since I believe this is the first time the committee is looking at an amendment, there's a couple of ways of structuring an amendment. And for this one, at least for purposes of our conversation, I've structured this as what we call a strike all amendment. And it's called that because of the lead-in language here, which, so it says this amendment is addressed to the House of Representatives, and it says this committee was referred this bill, H13, and its title, and you respectfully report that you've considered the same and recommend that the bill be amended by striking out all after the enacting clause and inserting in lieu thereof the following. And to start with, I've just copied and pasted the bill as introduced in, and then I'm showing you a markup version. So I think every attorney may have their own slightly different style for how they do markup. This is what I have developed, which is I like to show you changes from the bill as introduced using bold and highlight for newly added language and bold or highlight but not bold for potentially struck through language.
And do you want to say what the 3 asterisks are?
Yes, so and this was in the bill as introduced. These 3, we call them ellipses or asterisks, are just kind of a placeholder saying we're not touching this part of the statute. So as you can probably surmise, we're not touching subdivisions 1 through 6. We're starting with 7. So we're not amending them. We're not deleting them. We're just not showing them because they are not being proposed to be amended in any way.
Can you just zoom in a little bit? Thank you. Mike. It should be up there. Thank you.
Yeah,
Coming up on your,
it's on your computer now. If you
Thank you so much.
correct.
Oh, there it is.
All right. So what I have proposed to do in this version then of the bill as it came to you is to make a list. First of all, break this out into, it was getting to be a very long list. So broke it out into some subdivisions of what home and community-based services mean. So I didn't change any of the substance of what was in here, but I broke it out into a subdivision A for the first sentence, and then a subdivision B for the second sentence. And then I added, and you can decide if you want to specify the provider type. I took the language from the next section. But services provided by designated and specialized service agencies to individuals with mental conditions, individuals with substance use disorders, and individuals with developmental or intellectual disabilities. And that was the piece you'll see. Then I didn't make any changes in section 2, which is where we're using that term home and community-based services. But in section 3, where we'd had that parallel process for the designated and specialized service agencies, instead, I want to strike this A as well, but instead of having that whole thing repeated, I just had it say the Secretary of Human Services shall determine the departments of health, mental health, and disabilities, aging and independence, independent living's rates of payments for designated and specialized service agencies in accordance with 33 VSA 911, which is this other section. So we keep a provision, in my suggestion to the chair was to keep a provision in the DA and SSA statutes that just points to the process that we're then having just one consolidated list of providers for, or services for. And then I would strike, and in fact, actually repeal or delete the rest of that existing statutory section. And then that was it for changes, at least in this version.
Okay. So. I'm wondering, just sort of wondering out loud, Jen. I'm trying to make sure that we're inclusive of things that people might not currently view as home and community-based services has sort of been it's a term of art now that's been used for kind of specific things, you know, it's known in Choices for Care, it's known in the DS waiver, it's known in the, you know, in mental health services.
Thinking we should use a different term than home and community-based services.
I'm not really sure what I'm thinking, to be perfectly
Yeah.
honest. One, because my brain's not working very well today. But
I think there can be value in, if we can come up with something that's a little bit different, that doesn't create a different definition for a term that is often used in specific ways.
yeah. Yeah, John and then Ann.
I just am asking your question, is the reason to look for a different word or to try to frame this up is to, I sense we're looking at a way to provide language that's going to close a gap. And we're looking for a word that people will understand, or a set of words people will understand. It's this gap we're trying to deal with here.
Yeah, I mean,
If we get, I understand, it strikes me that if we get very specific and name everything, then as soon as if someone names another program, then it's not part of that. And it's out.
Exactly.
You don't want to create a gap.
Yeah, we don't want to create a gap by,
exactly,
Being too specific.
exactly. Yeah,
So I just brainstorming it, if we were defining home and community, the home and community-based service continuum means, then we'd be making it clear that we want to be comprehensive and not just a traditional home and community-based terminology.
That make it difficult only because I think we'd have to think about how we then talk about providers delivering services in the home and community-based care continuum. I mean, it might.
Providers along this continuum. Sorry,
That's fine.
yeah. Don't you think?
I guess just the thought I have is that I think I understand where we're trying to go. I worry a little bit if we don't use home and community-based services at all, does that create a level of confusion for a population of providers and others who look at this as to what their expectation is of what they're going to see?
Right,
And they think, oh, well, that went away. They're not providing that.
it doesn't mean us anymore.
Yeah.
I mean, I think what's most important, at least from a legal standpoint, is the part after whatever phrase you say means, and then what it means.
Yeah.
Right,
So we can come up with whatever phrasing you want, as long as what it means includes
Sure.
all of the people you are trying to include.
And the standard language from, if you see, as used in this chapter. So it makes it very specific. When we say this term here, this is what we mean by it. Yeah.
yeah, I mean, so part of what I've been sort of toying with is actually making this simpler long-term services and supports provided to older adults and adults with disabilities. Not, so just kind of hear me out, in a home or community setting other than the nursing home. Period, and not actually mentioning choices for care, you know, because then it's, I mean, it's however Vermont's Medicaid program is going to be named. I mean, it's, so, that also captures ACCS, which is not choices for care.
We have that.
Right.
I think if you, my concern is if you don't name at least some services or programs, that there will be confusion or ambiguity about what is and is not included. So I think then you're providing potentially discretion to the agency to determine
Yeah.
it's in that category.
Okay, Eric, Doug, and John.
Just quickly, I just went on the Medicaid.gov site, home and community-based services. Home and community-based services provide opportunities for Medicaid beneficiaries to receive services in their own homes or communities rather than institutions or other isolated settings. The only reason I wanted to share that is because obviously it separates like an institution tile and tile setting in regards to that community, which would say that what I would define an institution being like, would that support a Valley Vista or a those types of settings? Am I off on this?
Say that last part again.
If it's referred to home and community-based services means that the services are being in homes or communities rather than institutions or other isolated settings. So this language wouldn't apply to being able to extend on over to maybe a place like Valley Vista or other things that may be recognized.
As a residential treatment for substance use
Yeah.
disorder.
Yeah.
That's a question maybe I can ask Monica. Do they have Medicaid at Valley Vista?
Do they accept Medicaid?
Yeah,
Yes.
we do. And as a just as a residential service of some sort, as a substance use residential service.
Yeah, it's high level, it's treatment at the highest level for individuals with substance use disorder, so not really sure that would count as long term.
Right, that's what I'm thinking. I'm thinking like it actually might be included in this definition. Because it's not long term.
Mhm.
You see what I'm saying?
Yeah,
Um,
and they're not considered an institutionalized setting.
No, they're not.
Institutionalized setting would be
Yeah.
more a correctional facility.
Well, nursing home is.
nursing homes are considered institutional service. Yeah,
But-
well, the second we had
Yeah.
Doug, Zon, and then Ann.
I think maybe we moved away from that, but the Valley Vista example to me seems like it could fall within the definition of isolated. Doesn't seem to me to fit with a traditional community-based. But that's just sort of a gut response, not being in the details of that. But I worry, there's choices for care in the other language we were talking a moment ago about possibly removing. Does that appear currently in any statute? And I ask the question because I'm a little worried if we take that out, does that seem like could that be interpreted as some sort of legislative intent with the removal of it?
I mean, I think right now we are doing a description of types of services. The Choices for Care program itself exists both in our agreement with the federal government under our Section 1115 Medicaid demonstration, and we have a couple of statutes that address a specific aspect of it. And there's nothing in statute that you are removing. You're just looking at whether you want to add language in a bill or not.
Thank you.
Yeah, I mean, the way this is structured is like, choices for care, right? And then those non-choices for care services, but that are also Medicaid services. And then, in C, that's services for people with, mental health challenges and developmental disabilities. And, And I don't know how it's referred to. It used to be called DS waiver, but I don't have no idea if that, it's not like choices for care. That's sort of like it's a nomenclature that's been,
It was a waiver program, now it's part of our
yeah,
larger
Yeah.
administration.
so, I guess, I mean, all three of those things are under Vermont's global commitment to health. So that part of the sentence applies to A,
Well, that
B,
was-
and C.
Pursuant to the choices for care component of global commitment to health. So it's just in A, it's talking about those services provided pursuant to the choices for care component of our global commitment to health.
Yeah, I get that. I just am, I don't want to infer that these other things are not part of global commitment to health.
That's not how I read this. I think it's just identifying the services that are part of the choices for care component in A, but we don't have to include a reference to, I think that was originally meant as more of a descriptor. And the list of services has grown in the time we've worked, over the sessions that we've worked on this language. I don't know that you need to have that reference to choices for care in there.
So maybe we put it, maybe we put it up under home and community-based services, means services and supports funded under better components of Vermont's global commitment to health. We put it up in the
No, lead in.
lead-in that then applies to all three. So I think we had John and then Ann, yeah. Okay. Yeah.
So I'm finding it a little bit confusing in going back and forth between examples of the type of service and examples that are based on who is being served.
Mhm.
So in B, we've got a list of types of service, and then also basically, any services that are for individuals with traumatic brain injury, which could include institutional theoretically. And then C, likewise, it's any services. I'm not sure if that distinguishes services, arrange. For instance, does a designated agency provide through a referral to Valley Vista for substance use disorder, and so forth? Does that, are PMNIs, well, no, we're limited
No.
to adults.
Yeah.
Well, actually, C doesn't say adults. So C would include children, although our earlier intent had been adults with that.
Well, it would include children's
It would include
services provided by the designated and.
That had been in its own separate section and now
Right.
combines these into one section.
But not other home and community, well, non-choices of care would include children. The choices of care, A would not include children. B and C would include,
Yes.
could include children.
So do you have a suggestion?
No, I'm just observing, I'm not suggesting, it's sort of what do we intend to cover?
Yeah.
And then the language rather than suggestion.
So I know we're bouncing around a little bit, but in this sort of one section, in C, Jen, correct me if I'm wrong, but I read this as services that are by specific providers.
Yeah, just because I took the language that had been in its own standalone section and put it in here, right, just for purposes of for the study.
So I don't think that we would mean to exclude, what it's making me think about is, other providers, who provide substance use services that are not the designated agencies. They should be included in this, and the way I read this, they wouldn't be included.
I think the way the bill came to you, they would not be included. We
Yeah.
can certainly add them.
Yeah.
So you're wanting to take out specifically the designated and specialized service agencies, and then we still have that reference to this chapter for
Yeah.
them. So
Yeah.
for this.
Yeah.
And
Because then that keeps it consistent with A and B when we're talking about services and not providers. Any other thoughts? So just so people know, we'll see multiple versions of this. So what will happen is that Jen will go back and she'll make changes based upon our discussion. She'll bring back another version. We'll look at it again. We'll probably make other changes. We'll get feedback from people sitting around the table and people sitting around about whether or not this is, we may have suggestions for language.
First up, it appears later, and this is just a question about, it's lowercase designated and specialized service agencies. If those are a term of art, do they get capitalized?
No, because they're not the name of a specific entity.
Okay.
We rely on our editors for those things. The drafting rules about what gets capitalized and what doesn't seems to change from period to period.
It has changed.
We have, yes, we have done a fairly significant effort to clarify so that specific named entities, specific named positions, so names of agencies, which when I came were not capitalized. Almost nothing was capitalized. General Assembly was not capitalized. We now capitalize, but we try to make that distinction between something that is the official name of something versus a type of, like the designated and specialized service agencies are a type of organization, right, but not the name of a state agency or department.
That answer your question, Doug?
I understand, I guess I understand not the lack of capitalization. I know we're in the weeds here. But if someone is just reading this section, would one know that we're talking about a very specific group of agencies when we're talking about the DAs and SSAs?
Which is why I think we're removing that phrase and sticking to services. Okay, so, let's leave that section for now.
Can I just add
Yeah.
one other thought? If we are changing it to just services, then we need that part to also distinguish between, institutional services. Because if it was services, the way just dropping the DAs and SSAs, it would include inpatient hospitalization.
Well, no, it's a subset under home and community based.
Right.
Putting in.
But we're putting the definition of that at including C. So the definition of home and community based would become.
Right, so you want to say services provided in a home or community-based setting to.
Right.
Right. Okay.
Yeah.
So, so then the next section talks about the process for the Secretary of Human Services to determine the rates. So this is where we had some discussion in committee and from testimony that this piece essentially has been in law for a bit of time. Don't remember exactly when it was done. But it actually hasn't been happening in the way that it was expected to happen. Let's just put it that way. That's the sort of legislative intent, that there will be a periodic cost studies and then an annual inflation factor. And the bill that I recall us working on previously, Dan, had the Agency of Human Services providing a report or recommendations to the legislature. So I guess that's where we have to, I guess, have a decision point. So I don't think anybody is debating the fact that the Secretary of Human Services has the responsibility to determine the rates. I think that's just referencing it back to the previous statute. That's sort of the connecting piece that Jen was talking about. But I'm just thinking about this whole section, two. That has been a bit troublesome. Because theoretically, the secretary has this responsibility already. And it doesn't really happen on a regular and routine basis. Yeah, go ahead,
So
Rick.
I'm wondering, when I was reading this and looking at my notes and kind of thinking about the testimony would it make sense to say, set a frequency that they shall determine review
No
it
less
in-
than,
no less than every, I don't know, 3 years. I mean, annual, I think is cumbersome,
Yeah.
I think that's unreasonable, but I think if we set a frequency, then that ensures that it's not like done in this, oh, we prioritize wherever the needs are, but we need to come up with a plan to do it, all these services that fall under Medicaid in a set frequency.
Well, it says at least annually. On page 3.
Right, redetermine at least annually on page 3 in subsection D.
okay, the redetermining, yeah.
Right.
Is that the same as the rate study?
No, it's not the same as a rate study. I think between C and D, you have the secretary adopting rules with a methodology for determining payment rates, including an annual inflationary adjustment, a predictable timeline for redetermination of base rates, and then the redetermination of payment rates has to be done annually, at least annually, and reported. So I don't think I think the rate study is a more, I would look to the AHS book, but I think that is a more in-depth
Right, which,
look than rate redetermination. I don't know how frequently it is useful to do a rate study.
but determining the rates annually, I mean, couldn't we argue that by submitting a budget, they're doing that? If they're submitting no increase, they're determining the previous year's rates.
Well, they're determining a rate, but it's not based on the cost of services.
Right.
So I think, so I guess I'm not disagreeing with what you're saying, but I think keeping in mind that we have to think about what the cost of services are. And
And it says in accordance with this section. That line 12 and 13, so that redetermination, at least annually, has to be a redetermination in accordance with that, so it would require the elements. I think.
And I guess I would, look to probably Alicia a full-blown rate study. What would be, I'm thinking like once every 5 years.
That's what I was thinking.
Yeah.
But I think it makes sense to actually
Put that in.
put that
Yeah.
in to say that we
It would-
want that done every 5 years. So then the rates are set based on the most recent rate study, and we don't have what happened, a few years ago where it hadn't been done in so long that it was like 79, 80%
Yeah, yeah.
increase were needed.
So I think that, I think the way section 4 reads now is that that's a one-time occurrence. Yeah, so I think that we would want that to be once every 5 years.
And
Minimum 3 years necessary.
But yes, I'm looking for where in section 2 to put that. I think they can do that.
Want the rate study in section 2.
I think we're gonna put in a requirement that they conduct a rate study. I mean, I'm not gonna put all of the language from section 4 into section 2. I'm just would require them to do a rate study at least once every 5 years.
Would we want to set a date for the first?
I think I mean, you have the first one in section 4.
You did go right up on line 11, shall determine payment rates at least every 5 years, and then later it's the annual
Yeah, I'm feeling like the rate study should come before the
Yes, that's.
instructor one.
That's what I had, that was my instinct a few days ago, was that seems to be what we're trying to really get at, is to set the rates,
And then move on.
and then move on to.
Have an understanding of
So
what-
if that whole section 4 would become section 2, or is that?
Well, I think they're two different, so that I think the drafting part is different from your concept. So I just want to understand, are you wanting to put something in section 2, which is this ongoing statutory requirement that they do a rate study at least every 5 years? And that rate study then informs the payment rates that they're developing in the rest of section 2, and also have them do the rate study in section 4 and potentially not have the first new rates, information coming in the methodology until they have done that rate study.
I don't think they're gonna be able to do that rate study on all of the services that are outlined. So I am thinking that we need to put in here something about providing a schedule of rate studies for the home and community-based services. So
Okay, so there is language in here already that requires the the rules to include a predictable timeline for redetermination of base rates. So maybe we could put something in there about a schedule for
the initial.
for renewed, for rate studies on different providers or
right, I would suspect that they would probably group certain
Yeah,
certain services together.
and then have it on a rotation.
On a rotation, yeah. Dan?
Yeah, no, I think that, you're not gonna do them all in 1 year, but if it was like so many per year with no more than 5 years between. But also, how do we do it with, how is it worded in nursing homes? Are we just statutory rate increase, or do we look at what the rate, like what the costs are before we assign the rate increase? Or is it just like so much percentage each year, regardless of what it costs to deliver the services?
I'm not sure we want to replicate
No, I was just wondering what I'm not looking to replicate, I'm just wondering how it's
how
there.
it's worded. I don't know how much of that is in statute and how much of that is in regulation, to be honest.
Right, there's the division of rate setting, basis for determination of nursing home rates. I mean, put it up if you want to see it.
Essentially, that's what we're looking at. We're looking at like, how do we not fall behind? Even though our nursing homes need emergency financial relief, even though there is a statutory increase anyways.
It's a payment system based on cost categories, at least including direct care costs, indirect costs, and property and related costs. And then resident classification. I mean, I think a lot of the details of how it works are in rule. But there is some language about inflation factors, changing in base years, how frequently those have to be updated.
Yeah, go ahead.
create, if we're staggering a review, setting the base rate for different settings, do we unintentionally create a tension between those different settings and where the professionals are going to work? If there's a setting where the rates, the base is determined in year one of a 5 schedule, workforce anyway, where the pay is updated most recently and is the best.
It's not realistic to expect them all to happen at the same time. So the answer is maybe,
Yeah, but we can't.
but, we, you know, the intent is to, utilize existing contracts that the department has and to make sure that this work is prioritized. I mean, that's what the intent is. So, yeah, I'm not gonna say that somebody might move from place A to place B, but that's why I think, you know, we can leave it up to rate setting to sort of appropriately group the services that they would decide to tackle in any given year.
Madam Chair, before I
Yeah.
have to run out,
Yeah.
but before I leave, I made a note when we first heard from Monica. And then the secretary reminded me that we want to make sure that we protect or at least acknowledge the possibility of the services that are being offered might be cut because of this. And the secretary yesterday mentioned that, you know, right now we offer a bunch of services that are not required by CMS, but we offer them in Vermont and cover them. So just want to make sure that we protect against that, or at least acknowledge that that's a possibility that.
I mean, I guess, you know, under the, who knows? Yeah, I'm not really sure how to tackle that one, Ray, to be honest with you. Yeah, I mean, could there be something wacky come out that only, you know, required services be the only ones that Medicaid, you know,
No, I'm
is-
saying
this
for
is
Vermont.
budget.
I know, I'm
yeah,
just
yeah.
saying, could that be it? That is
Yeah.
definitely something that could come out of this administration. We don't know. And that, yeah, I mean, it does mean that Vermont would be making some hard choices about what it continued to provide. Because we wouldn't be able to just pick up all the Medicaid services that are optional and pay 100% state funds.
Right, so I'm saying regardless of what the feds do, I want to make sure we protect what we currently offer. So in other words, I worry about the administration saying, well, we currently offer more than the feds require, but because we have to increase the rates, because of the rate studies, we're going to limit some of those services in order to pay the rates that we need to for this. So it would kind of prioritize certain services.
I think that's two different things, to be honest.
Well, right, I think this is, they're gonna be required to set rates, but it ends up coming to legislate. It's like, so do they set the rate and say, but we're only gonna pay 70% of it, because that's all. it's in
We
the
have, okay.
And then we have to look at, well, wait a minute, what impact does that have on
On the other
mandated or other
services, okay.
services? Based on what they bring to us, based on the rates.
Yeah,
Because this does not say we're paying those rates.
right,
Right.
Look at REACH.
right.
It just gives us the information
Information
to
about-
prioritize and make those judgments.
Okay, that makes.
Everybody understand that sort of last interchange?
Sorry.
Okay, no, it's important that we're kind of living in uncertain
Yeah.
times right now, so. Trying to, you know, have legislation make sense under, you know, all the what if
What if,
scenarios.
yeah.
Is, you know, not,
Tricky at
yeah,
best.
not easy, so, okay. So any other thoughts here about, changes that you would like to see. Dan, you've been thinking about this a long time.
Yeah. No, I mean, I think. Yeah,
Yeah, I do have a question, and this is a beginner question, simplistic perhaps. You said earlier that there's that a fair amount of this already exists in statute and expectation. And so by the fact that we're restating it, to what effect?
Well, this version of it requires a report to the legislature.
That's the rate. Yeah, I get that part. Okay, but the section 2 and 2 and 3.
I would say the language is a bit more active than the current language.
Are there-
Current language has been read to be more passive authority than a requirement to act.
Mhm. The previous one was more
The
passive.
current language, yep.
Right, there's been debates back and forth about it, whether it actually required them to do anything.
So,
So,
and
Jen
now,
is-
and now we're saying they shall.
Yes.
Okay, yeah. I see shall. I just want to make sure it's moving forward.
Nolan,
For the record, Nolan Langwell on this. Can I make a suggestion? Because
absolutely.
I think you're trying to sort of think about how it's scheduled for, why not make that part of the rate study, have them say they shall come up with a schedule with who gets what over what, you know, and you can set the time parameters no more than 3 years, but let them determine if we're back to you, then it'd be like.
That's what I put in their
That's
rulemaking.
what I was talking
Yeah.
about.
Yeah, you-
I put it in their rulemaking. That's what I'm working on it now, that the rules would include or would provide a schedule for conducting studies of the Medicaid reimbursement rates paid for the providers in home and community-based services with the rates for the providers of each type of service studied not less than once every 5 years. Think is what I heard.
You going a
I
different
was
direction?
saying- No, I was saying the same thing, but I was saying put it in the rate study.
I think the difference with rulemaking is it allows stakeholders to weigh in.
Yeah.
It would allow for if for some unforeseen reason, the agency actually thinks they should do the whole thing in 1 year every 5 years, rather than, you know, that's what they would come back with, schedule.
Yeah.
We're allowing them, for them to break it into pieces with each one in 5 years, but
Are there thoughts or questions?
Yes. Sorry.
You don't need to
Well,
apologize.
it's the learning those.
Exactly, it's all new. This is a new process for
Yeah.
lots of you.
So I guess my question would be to you two who authored this a bit prior. Is this getting at the furthest back, as I understand it, is the intent to do these rate studies and then to get the rate study done and then to have rates actually set on a regular basis that we can use in order to evaluate budgets and make sure that they're going square. So does this do that to your satisfaction?
Yeah, I mean, if the proof would be in the pudding, right?
Right, if the-
But it sets out a process, and sets out what I believe is a requirement, that the secretary establish rates. And then, like Ann said, they could opt to say, well, we're only paying 70% of those rates because that's what we have in the budget. And then it also requires that that information be submitted to the legislature so that we know the information on which to base, because trust me, when you hear from the designated agencies and the area agencies on aging and the home health agencies, as you look at the 26 budget, they're all going to be asking for, I don't know if the long-term care crisis coalition has come up with one percentage like they did a couple of years back, but, they're all gonna be asking because there was no cost of living or inflationary increase in the governor's budget for any of the home and community-based services, so, so they, really are forced to come to the legislature to have any impact on that, and, so, yeah, I mean, I believe that it does. I'll have to read it carefully my head's not as foggy as it is today. What do you think, Sam?
In terms of,
Could this be
Where
what
we're
we
going?
were? Yeah,
yeah, I mean, I think that having those rates so that we can look at where there's deficiencies in what we're funding or what's being proposed in a budget is important. I mean, we saw that when we had the last rate study, and we saw some line items were 80% off, or,
Yeah.
we were only funding a very small portion of it, which we determined was less than what we wanted to see the state funding them.
and so priority wise, we had a whole list of the outcomes from that rate study, and we chose to divide some of them up. And we've actually only funded, part one of some of them and not parts 2 and 3, but residential care homes, for instance, we funded the entire rate difference that year because we have to think about what it is that we are also looking to support in our communities, so what are the things in the sort of continuum of care that we want to assure? So while we have, bona fide process and necessary services in, nursing facilities, residential care homes, which can provide an alternative for people who need, 24-hour place to be. It was so far off. Why would people take a person who had Medicaid as their payer?
It also allows us, when we see increased pressures on different parts of the care, we can say, okay, this is happening because, we're underfunding, or it allows us to, I think, better think about where we can allocate the limited funds we have in order to make the greatest impact. But if we don't have the information, then we're guessing.
We're guessing based on, I'm not sure it's the right way to say it, but which group of agencies are most articulate and able
Yeah,
to organize to
sitting
really
here.
show us the need, and it's a valid need. But then there are ones who don't have that voice, who may be totally left behind. We really need to know on
Right.
somewhat of a
And that's what this is.
factual basis of a comparative, yeah, and that's
okay.
what this would
I
produce.
just want to make sure that's what this is doing for our purposes, so that we can help support what's out there then.
But also not to be so naive to think that, okay, we can look at the fact that, we underfunded Meals on Wheels and therefore we're seeing more uptake in people going to nursing homes. I mean, it's hard to draw those direct lines, but it's probably impossible to figure out like individual, when you're trying to look at it from the 20,000-foot view or from our view, to say, okay, what's costing these, but at least having the rates, you're maybe having another piece of the puzzle, so you can try to look at where people are receiving their care or how they're aging in Vermont. So
Thank you.
I guess that makes sense. It's really hard to draw those conclusions, but at least if we had some
Objective basis
something.
for comparing.
I think you can draw, I feel comfortable drawing conclusions around, when you're comparing similar residential types,
Yeah.
for instance. So if we don't support residential care homes, we lose them. We know that.
We know-
Once we're in
They close
a
down.
beds, They
They
close
close.
down and they're no longer an option for people. And then we end up utilizing more highest cost services, which the secretary went over in her overview of the budget.
Mhm.
There's another, I can't remember the exact number now because I've got BAA running through my head, but there was over 50 million in BAA, and then there's another big chunk of money in the 26 budget for the most expensive part of our system and not doing anything for the rest of the system.
Right.
And that just does not make financial sense, frankly.
Correct.
I think the hard part also is to be realistic that we can see the lack of funding for a particular, but if we only have so much money, so we, you know, it's hard when you lay out all these rates and say, well, this should we should be paying this for this, this and this, but then, you know, you don't have that ability and the expectation, you know, to fund it all at 100%, is not what we're trying to do here. We're trying to just see where there's holes.
And I think, you know, this area is a subcategory that people in general are less aware of. The analogy that a lot more people, because it's been more public maybe, is, you know, why do we need to invest in primary care to keep people out of hospitals? Because we intercept problems sooner, they don't get more acute and end up in the highest level of, you know, medical hospital care. Same kind of, and you can't prove that directly, but you can make clear associations and recognize.
So I'm just trying to sort of plan out where we'll be. We have Jen back later this afternoon. I'm making a presumption, Jen, that it would be with revised language.
Yes, I think I've been revising it well with.
And we get told that don't expect Ledge Council to be drafting.
But I suggest it.
I'm like, I don't expect it. I just,
But some of our most long-term experience
she
folks.
is a whiz at doing that. So,
Yeah.
So back at 1, we will have another version to look at. So, and then, today's Thursday, right? Okay, so, if people are feeling, okay with where we end up, then, I'll probably put it on for a vote on Tuesday, at a committee. So that means we like to put it on our agenda so that people know in advance that there's a possible vote on Tuesday. That way people have an opportunity to look at what the, you know, the most recent language is and provide any sort of feedback that they might want to provide us.
Yeah, it doesn't, in other words, doesn't lock us in. It
No.
may bump it back a day or whatever, but it's the notice, public notice piece.
Yeah.
Yeah, possible vote here, folks. We're getting to the
Okay.
final phase.
And then because this impacts provider system, I'm going to just give the chair of healthcare heads up. It'll probably go there for it might just be like a drive-by kind of thing where they don't actually take possession of the bill. But after we have a version that we're feeling is going to be close to the final version, Jen will go next door and, you know, present that to them. And we would take any feedback that they have and consider the feedback. And then if they're feeling really strongly about it, the chair may ask to take possession of the bill, which she has the right to do if she wants to. But usually on something like this, it probably is not going to be a possession. It'll probably just be a drive-by, and we use drive-by, fly over, you know, any of those things. And yes, very technical language.
Right.
And then we'll get feedback from their committee. So I think I'm gonna let the chair know about this, that we have a pretty good draft coming at us this afternoon. So maybe their committee could squeeze it in tomorrow.
Again, we don't have all the new folks, but whenever we talk about the designated and specialized service agencies, we're talking about something that's half healthcare and half us, because all of the mental health services that the designated agency, mental healthcare is in their committee, and developmental disabilities in our committee. So this covers broader than just specialized services. So it's not, 50% of the bill, but that's where their biggest piece comes in with this particular bill.
Okay, I think we're all set on this, so we'll have a little bit longer break. Our next witness is at 10:45. And